Hello, I'm Biykem Bozkurt, professor of medicine from Baylor College of Medicine, and I'm very happy to introduce Rob Mentz from Duke University, from Duke Clinical Research Institute, to discuss the transform trial, the torsemide comparison with furosemide for management of heart failure at the AHA Science News. Rob, this has been a long-awaited trial. Tell us about the Transform trial. What did it examine? What did you guys find?
Well, Beacom, thanks so much for the opportunity. On behalf of our participants and investigators, we're delighted to be able to share these results that really do inform clinical practice. Transform HF was a large, randomized, pragmatic trial that compared head to head two common loop diuretics in patients living with heart failure. So, just as you noted, it looked at furosemide and torsemide. And how this was set up was to identify patients while in the hospital here in the US at 60 sites and to include them in this trial in a randomized fashion, and then randomization to the strategy of furosemide or torsemide. And importantly, we wanted this to be broadly inclusive. So it included heart failure patients across the spectrum of ejection fraction, whether this was their first admission with hospital with heart failure or they've had a longer standing history of heart failure. And then following that randomization, we wanted to reduce the burden on the participants and sites. So all of the follow-up was centralized by the Duke Clinical Research Institute call center, and patients continued through their usual care in terms of their routine clinical providers. We had mechanisms in place to support adherence to the randomized therapy, and then we collected clinical outcomes. Our primary endpoint was all-cause mortality, and we looked at other important endpoints for our participants, including hospitalizations. We looked at a composite of all-cause hospitalizations and all-cause mortality, as well as total hospitalizations. And in brief, what we found is we recruited over 2,850 patients, again, one-to-one randomization to these two strategies. The population was quite diverse in terms of representation. We had 37% women. We had 34% individuals that self-identified as Black. It was about two-thirds had a history of heart failure with reduced ejection fraction. And then importantly, during that follow-up period, we observed a very high event rate. For our primary endpoint of all-cause mortality over a median follow-up of over 17 months, we did find that there was no difference between torsemide and furosemide. About 26% of patients died in follow-up, highlighting how high the event rate was in this group, but no difference between these two diuretic strategies. In addition, for our secondary endpoint of all-cause hospitalization and all-cause mortality over a 12-month follow-up, again, similar between these two groups, but importantly, very high event rate, 50% of patients approximately having either a death or a hospitalization during this time. So in summary, we compared head-to-head these two commonly used loop diuretics and found that they were similar in terms of clinical outcomes, including mortality as well as a composite with hospitalization.
Fascinating results, Rob. So tell us, why did you all conduct this trial? What was the reason for this head-to-head comparison?
Thanks so much, Beacom. So with this trial, we really wanted to answer this fundamental question that comes up every day for clinicians taking care of patients with heart failure who are accumulating fluid or at volume overload. And very often what we've seen is that patients are commonly started on furosemide, but then as their clinical course worsens or they're appearing to not respond as well, they'll be transitioned to torsemide. There are some important pharmacologic differences where torsemide has a longer half-life, it is better absorbed, including in patients with heart failure. So there's this perception that it may have clinical outcome benefits as well. There's, in addition to these anecdotal experiences, there are important preclinical data that demonstrated actually improvements in terms of the fibrosis or the scarring in the heart, some biomarker changes that appear advantageous with torsemide that we don't see with furosemide, specifically anti-aldosterone effects, maybe even some ventricular remodeling benefits, and some observational studies that show that there might be a reduction in hospitalization as well as mortality. So with that background, we felt that the definitive way to answer this question was through a robust, randomized clinical trial that compared these two diuretics head to head so we could definitively answer which one of these is better to help inform clinical practice.
So, can you tell us what are the clinical implications of this trial for the clinicians?
To really summarize the key clinical implications from this, number one, we really looked at this foundational common question that comes up about one loop diuretic versus the other. And now we have definitive evidence from a clinical trial that there is no difference in clinical outcomes between these two. Rather than spend that time, whether in the clinic or the hospital setting, talking about diuretic strategy, we really should make sure that patients are on the right dose so we can adequately decongest. And that time can better be spent by making sure we get our patients on the right dose uh, and continue to titrate those up over time for guideline directed medical therapies. We need to emphasize those therapies that we know improve outcomes for our patients. And finally, while we did not look at a specific dose in this trial, further insights will come out that will help us better understand how dose may have played a role in addition to the diuretic strategy itself.
Thank you, Rob. Very important implications. I would like to thank you and the investigators for conducting this very important pragmatic trial, our patients and investigators who participate in the trial, and our audience who are listening to us at the AHA Science News. We look forward to your future participation in similar sessions in the future. Thank you.